Good afternoon, everyone. At the outset, I would like to thank the organizers, Prashant, Safalta, and everyone who is involved in this participation program. Now, my job is to discuss mantle cell lymphoma. I don't have any conflicts to disclose. So this is the plan of presentation. I will discuss a case. We'll discuss some basics, pathology, and biology, and treatment we will discuss in detail, past, present, and latest. So this is a 62-year-old gentleman. He was diagnosed as mantle cell lymphoma, high risk at a private institution. He was stage 4. It was mainly on the peripheral blood. He was suggested treatment. He lost to follow. He took alternative treatment for close to 1 year. Now he presented to us in 2019 when COVID was thick with the airway obstruction, which was predominantly oropharyngeal, not causing a lot of respiratory issues. He was stage 4, peripheral blood. He denied doing a bone marrow. I would not have done it. Flow cytometry was suggestive of mantle cell lymphoma. He was high risk after we have discussed the lymph node biopsy. We suggested treatment with BR. He didn't want any form of chemotherapy. Now, please keep on guessing. How should we treat him? No, I'm sorry. So the basic features of mantle cell lymphoma among all the lymphomas, they are CD5, so the incidence is 5%. The male is to female ratio is 4:1. The median age at diagnosis is in the 6th and 7th decade. By convention, most of them are actually advanced stage at diagnosis. The leukemic phase could be seen in 1/3. Extranodal presentation is the rule. GI tract involvement is close to 80%. Even when you do not find any polyps and you go for a blind biopsy, there is involvement. And the clinical course is variable. It could be something indolent to aggressive like blastoid. So these are some basics. I mean, we do not routinely perform translocation assays by fish. If it is cyclin D1 positive, it does the job. Lymph node biopsy is not mandatory, but having said that, cyclin D1 can have some issues with bone marrows because of some technical issues. The typical immunophenotype is it is a CD5 positive CLPD, which is CD23 negative. CD20 is bright. FMC7 would be positive. CD200 I have not mentioned here, it is negative. Fish is mostly not required. So these are the common histological subtypes. Now the ones in the first two, they are low risk. One is a classical and the other one is the small cell. Now they could be pleomorphic as in this figure C, and they could be blastoid as in figure D. At times what you could find in a lymph node biopsy, you can have combination of any of them. Okay, so when you look into the mantle cell lymphoma, they're very it's a West basket diagnosis. There are many type of presentations that can come to you, and if you look into the pathogenesis, they could be hypermutated, and just like in CLL, they could be mutated or a small hypermutation, or they are crossly hypermutated. When they are hypermutated, they tend to be SOX11 negative, which is commonly seen in cases of mantle cell lymphoma. These patients, they have non-nodal presentations. They are restricted, the problem restricted to only peripheral blood and bone marrow. It comes around 10 to 20% of all the cases of mantle cell lymphoma we see. They are CD5 commonly negative. They are SOX11 negative. They tend to have low Ki67, that is less than 10%. They have somatic hypermutation. There are fewer genetic alterations, and there are infrequent genomic complexity. So they are a lot simpler malignancies. So they can be mostly observed. Now, I will go to the other extreme, which are the blastoid or the pleomorphic type of mantle cell lymphomas. Now, they are close to, I mean, if you also include the classical, they will be close to 80 to 90%. They've got high risk morphology. They have high Ki67 and P53 expression. They got a lot of TP53 mutations. And especially those patients who have got blastoid type, they can have CNS involvement. And in between these two presentations, then there can be classical mantle cell lymphomas. So especially the non-nodal type of mantle cell lymphoma and few other classical type of mantle cell lymphoma, we may not jump on the treatment. They can be observed. Now, this is a very old study by Peter J. Martin. They have included patients. They have not jumped on to treating them straightforward, and they have waited. As you could see, the median time to start treatment is close to 12 months. So, which is okay. I mean, in mantle cell lymphomas, if they are not blastoid, no high Ki67, they can be, you can actually wait before you jump on your sort of treatment. And those patients, these patients, they can be actually, this is a clinical MIPI scoring. You can classify them into low risk, intermediate risk, and high risk. I won't go into detail. So mantle cell lymphoma could be early stage by literature. This is rare, but please be careful. The role of endoscopies in these patients are more important than in advanced stage. These patients, you need to do endoscopies. If there are no polyps, you do blind biopsies. If they are biopsy positive, they are not early stage, they are advanced. But if at all you have done everything and they are found to be early stage, go with a chemotherapy followed by chemoimmunotherapy followed by radiotherapy. If I take a corollary from a prior presentation where in follicular lymphoma, they were given radiation as a single modality, these CLPDs are a lot more aggressive than follicular lymphoma, and they tend to have relapses. So chemotherapy followed by radiotherapy, just like in a DLBCL type of treatment, they may be a little more responsive. So these are the first line recommendation as of today. The first line is recommended in advanced stage, which is starting from stage 2, which is bulky, then 3 and 4. We divide patients into two types: those patients who can take intense treatment and transplant eligible, and those who are transplant ineligible. Those who are transplant eligible, you have so many options here. You can use an R-CHOP RDAP or a higher R-hyper-CVAD or a Nordic regimen or a Maxi-CHOP or even a bendamustine based regimen, that is RBAC. The other recommended regimen is also bendamustine rituximab, which is used in the older patients. But yes, they can still be used. I'll be coming at it. And those who are ineligible, you have to use less intense treatment, and BR is the standard. There are other regimens like VR cap, which was found to be better than R-CHOP. But yes, BR is a very common regimen here. Now, as consolidation, you tend to do autologous stem cell transplant, those who are eligible, followed by rituximab maintenance. And maintenance rituximab is almost to be used after every sort of treatment, be it BR, be it R-CHOP. I have not made a slide, but it is useful in all the scenarios. So now, when we look into this BR versus R-CHOP game, these are a subgroup analysis. You could see that BR has got better PFS as compared to R-CHOP, even though the overall survival is not different. So now this is the first question. In patients who are transplant eligible, do we need to do intense chemotherapy? Now this is S1106 study. They had two arms. This is a phase 2 randomized design. In one arm, they have given only bendamustine rituximab. In the other arm, they have given R-hyper-CVAD MA protocol. As you could see, there is no difference in PFS as well as in overall survival. So even though the patient can tolerate more, you may not give them more. And now let's come to all these chemoimmunotherapy regimens. There have been a good randomized control trial between R-CHOP versus R-CHOP RDAP. By adding RSC, the survival is improved. Now the question is, even in this chemoimmunotherapy era and RSC used as a companion drug, is autologous stem cell transplant necessary? This is the randomized study which I talked about, that adding RDAP to R-CHOP backbone, it improves the progression-free survival. Now, this study, which is close to 100 patients, this is almost an 8-year follow-up. And this was from MD Anderson Cancer Center. They have treated patients with R-hyper-CVAD and RMA without any autologous stem cell transplantation. And they have actually done well. And the results are actually comparable across the other studies where autologous stem cell transplantation was also used. Now, this is the recent study. It is still not available as a publication. It was presented at ASH, and it is expected to complete by 2026. Now, on the R-CHOP RDAP, this is a 3-arm trial basically. And okay. So this is the standard arm A, where R-CHOP and RDAP 3 cycles each, followed by autologous stem cell transplantation. Now they have added rituximab maintenance as an amendment, as you could see here. And in the other arm, they have only added ibrutinib to R-CHOP RDAP, and the same thing, I mean, autologous stem cell transplantation and 2 year of ibrutinib maintenance. Now, this second arm, if you could put your focus here, in this second arm, they have not performed any autologous stem cell transplantation. They have only given 2 year ibrutinib maintenance followed by observation. Now, after our maintenance was proven to be having a beneficial effect in transplant eligible patients, our maintenance was also given in all these 3 arms. And this is where the study, I mean, when you're using ibrutinib, you need to do one autologous stem cell transplantation as it is there. I mean, failure-free survival, it is just the same. And when you compare it with the standard of care, that is R-CHOP, RDAP, followed by autologous stem cell transplantation and rituximab maintenance, even the non-transplant patients, they are doing better. And there is actually no overall survival benefit. No studies as of today in mantle cell lymphoma in upfront, they have shown an overall survival benefit with regards to how you have treated them. So now the interesting point here, I don't want to go into the patient characteristics here. I want you to focus on the remission rates. Now, in the transplant eligible patient, when they are treated with R-CHOP, RDAP, and ibrutinib is added or even not added, in these two subgroups, if you could see, adding ibrutinib, it doesn't improve the remission rates. Okay, in the 6 months, in the 4 months period, it is not adding to the responses to R-CHOP and RDAP. But despite that, autologous stem cell transplantation is not able to produce a benefit. Now the question is, as of today, as we speak here, there are regimens which can produce better responses without the usage of chemotherapy. Now, this is the SHINE study. I have taken this cue from the transplant ineligible population where the standard of care is bendamustine rituximab, and whether adding ibrutinib can further improve the survival. As you could see here, the primary endpoint is PFS. Those patients who have received ibrutinib in addition to BR, their median PFS is 80.6 months. Now, if you go by the numbers, these numbers do equally compared. I mean, it is pretty much comparable to the patients who are transplant eligible and gotten all the high intense therapies and rituximab maintenance. The numbers, they look just the same. And when you look into the responses, yes. Now, this study is not powered to look for the responses, but nevertheless, there is some hint that the responses are also increased when you are using ibrutinib. And this is best. This is not at 4 months. Okay. Now, let's come to the more novel this thing. I mean, the question is, do we actually require chemotherapy in this era, ibrutinib and venetoclax era? This study was published in New England Journal of Medicine in 2018. They took patients who were relapsed and refractory. They were not very high numbered. I think the number was 24. There was only one patient who was treatment naive. And this was a protocol. They started initially with ibrutinib, then added venetoclax, just like in CLL. And when you look at the PET overall response rate and CR rates, it is close to 70%. Now, these are relapsed refractory mantle cell lymphomas. And the previous approved drug was ibrutinib, and the CR rates were close to 15 or 20%. Now, adding venetoclax, it definitely improves the CR rates. And if you trust these CR rates, they're even better than your treatment naive patient treated with R-CHOP, RDAP, with ibrutinib, with only 40% CR rates. Okay. Now, the same question. I mean, do we actually require chemotherapy in this area? This is another phase 1-2 study, ibrutinib, venetoclax with obinutuzumab, and they are just the same. I mean, repetition of same thing, that the CR rates are closer to 70 to 80%. I'll skip it. And this is use of acalabrutinib with venetoclax and rituximab. This was done in a COVID era. You could see even at a 2-year follow-up, if you censor the curve because of the COVID-related deaths, because ibrutinib, those patients which is ibrutinib, they have a higher chance of COVID-related death, and these are older patients. So at 2-year follow-up, None of them. The curves are pretty much straight. Now let's come to the worst of the black sheep, which is TP53 mutated mantle cell lymphoma. When you look into all these chemotherapy studies, having a TP53 mutation, they are not doing very well. So giving them more is actually not better. When you look into the SHINE study, which was transplant ineligible patient, BR versus IBR, even adding ibrutinib to bendamustine rituximab in these cases, it doesn't help. So IBR is also not very useful in these cases. This is a recent study where there was no chemotherapy given, only zanubrutinib, venetoclax, and obinutuzumab was used. It appears pretty okay. The CR rates are close to 64%, but longer follow-ups are required. So possibly, in patients who are TP53 mutated, the only drug which could be useful is ibrutinib, and additional usage of venetoclax or maybe obinutuzumab could be crucial. So these are the novel therapeutic approaches of relapsed refractory mantle cell lymphoma. Mantle cell lymphoma, there are at least 4 approaches. Either it is by BTK inhibition or usage of BiTEs or the ADCs. They are mostly unavailable. I know Prashant can get many of them. And then there is CAR T cell, which is Brex. Now, this is one of these simpler regimens, which is R square. Both these drugs are available in the country. And this is used in both frontline and relapsed patients. It has got good benefit in the frontline. Those patients who are not an eligible candidate for ibrutinib and rituximab, you could actually consider R square for these patients. And even in those patients who are relapsed refractory, R square is doing pretty much modestly. Now, this I can skip. Now, this is the BTK inhibitor data in relapsed refractory mantle cell lymphoma patients, those who have not BTK, those who are BTK naive. And when you look into the PFS, it is closer to 22 months when it is used as the just second line. And all these things like acalabrutinib, the same data, I think zanubrutinib, the same data, the patient populations are different. So the numbers might appear that zanubrutinib is possibly better than acala or ibrutinib, but it might not be actually so. Now, this is the new BTK inhibitor, which is there. It could be on a compassionate access if your patient is, could be, I'm not sure. Those patients who are progressing while on ibrutinib or acala or zanu, they can be salvaged with pirtobrutinib. And the median duration of response is 18 months. Close to 25 or 51% will have some responses. Could be a useful drug. And this is the venetoclax study. Venetoclax is not very, very useful. It is somewhat okay. The PFS for venetoclax is close to 11 months. Now, in relapsed refractory patients, there is now sufficient data of usage of both this ibrutinib and venetoclax. The CR rates are close to 60%, and the overall survival is closer to 2.5 to 3 years. Now, this is the newest therapy, which is a CAR T product. This CAR T product is something like Yescarta. It will be discussed in detail in the further presentation. Now, in mantle cell lymphoma, they have to do an extra step to take out the mantle cells from the CAR T product. So that's why the name is also different. Otherwise, it is completely similar as Yescarta. And you could see the CR rates are close to 70% here, and they have a good overall survival. In this study, bridging therapy was allowed with BTK inhibitors. So the overall survival curves, it could be a combination of the bridging therapy as well as the CAR T. Now, this is an age-old thing. Allogeneic stem cell transplantation in mantle cell lymphoma could be curative. And the only issue is many of these patients are actually not transplant eligible. They are older patients. The non-relapse mortality can go up till 20%. But yes, that is, I mean, close to 50% of these patients, carefully selected patients, they can be cured with allogeneic stem cell transplantation. Now, this was the case. I mean, we almost fought with him to take BR. He denied it. We gave him ibrutinib. And now it is 2 years down the line. He's in CR. His peripheral blood flow cytometry still shows evidence. Now, technically speaking, ibrutinib is okay for the nodes, and it is somewhat modest for the peripheral blood and bone marrow. At this point of time, if we use venetoclax, it would also clear the peripheral blood and bone marrow and become MRD negative, so that we can stop the treatment maybe in another 1 year. But he is not willing to go on venetoclax as of now. Now let's come to what we face in our clinic. Now all these drugs are expensive. As we add on more drugs, the economic constraints, they increase. Now, ibrutinib is a BTK inhibitor, and at a dose of somewhere around 2.5 milligram, there is close to 100% BTK occupancy. So 2.5 milligram per kg in India means closer to 140 milligram. In mantle cell lymphoma, the recommended phase 2 dose was 560 milligram. Now, why that dose was chosen instead of 420 milligram, I don't know. But if you ask me, if we go by science, any dose which is 140 milligram or above should be okay for mantle cell lymphoma. And this is another thing. I mean, when you give BTK inhibitor first, it also increases the BCL2 and BIM. So it prepares the ground for the venetoclax to act. And when you give ibrutinib and venetoclax, if you look into the pharmacokinetic interaction, ibrutinib increases the venetoclax activity. So all the past studies that I have discussed of using ibrutinib at the maximum dose, which is 560, and venetoclax at 400, there could be overusage of the drugs, which could lead to a lot of side effects. So here, as you could see, this study is done in CLL. They have given 420 in the first cycle, 280 in the second, and 130 in the third. As you could see, the BTK occupancy, it is almost as good with 140 and then 280 and 420. There is no difference. And when you look into the BCL2 and BIM expression, it increases. So if you use a venetoclax at this point, they can actually work wonder. But having said that, what is the right dose of ibrutinib and venetoclax to be used? Maybe in CLL or mantle cell lymphoma, it is not clear. This is one study which was done with that regard to know what is the effective dose of venetoclax and ibrutinib. Now, in this study, they found out that venetoclax dose at 200 milligram and ibrutinib at 420 milligram, it does the job. But you have to understand, they have used venetoclax first here as a ramp up, and then it used added ibrutinib at cycle 2. So if you ask me, if I have to use a sequence, I would rather use ibrutinib first, followed by venetoclax. By using ibrutinib, you are reducing the nodal load, so that the incidence of TLS goes down pretty perfectly. And if you ask me what should be the ideal dose if you use ibrutinib first, then venetoclax, I feel a 140 and 100 milligram dose should be enough, which is a gut feel. I'm not very sure. We need to do studies regarding that. And if we could use something like this, the cost of therapy can actually come down. Okay. So to conclude, treatment-wise, mantle cell lymphoma is the new CLL, I would say. In non-nodal mantle cell lymphoma, we need to observe them. In fit patients with mantle cell lymphoma, transplant should be considered because that result is yet to be published. If the patient is not willing for transplant, now you could use the triangle data. You could suggest him ibrutinib and rituximab maintenance. And the maintenance should be rituximab plus or minus ibrutinib. The future is possibly we are looking at only novel therapies without any autologous stem cell transplantation. And maybe at a state of MRD negative, we could actually stop the treatment. In unfit patients, it should be less intense, BIA plus or minus ibrutinib. I would do an ibrutinib and BIA in these patients. Those patients who are not ibrutinib eligible, Benda Ritux eligible, I would consider out R square. But I believe the future is only novel therapy. It is at least ibrutinib with or without something. In TP53 mutant, ibrutinib should be the bare minimum drug with or without venetoclax. These patients should be considered for allogeneic stem cell transplantation or CAR-T. In relapsed and refractory patients who are BTK naive, a covalent BTK inhibitor, ibrutinib, Acala, or Xano should be used. Those who are BTK inhibitor exposed and progressed while on BTK inhibitor, a non-covalent BTK inhibitor like pyrtobrutinib or CAR-T or allogeneic stem cell transplant in carefully selected patients should be considered. In low middle income countries like ours, when the money is a constraint, low doses of ibrutinib should be given. When, if it can be used, should be used, it could be cost effective because you are cutting down the treatment duration. And I would also suggest that we should also not forget about RSE. And let's be imaginative. In those patients who are very poor, RSE could be a useful agent, not at the dose you believe, that is high dose RSE. Even low doses of RSE should be very effective. That is my last word. I'll be happy to answer a few questions.
As usual, very nice talk, Ranjit. So it is completely agreeable and understood that for nodal lymphoma, your choice of ibrutinib adding sequentially venetoclax is very much fine. My question is for that small subset of SOX11 negative leukemic phase of mantle cell, which is almost akin to CLL. Now, in case that patient needs some kind of therapy, then would you again go to the go-to drug ibrutinib or something less intense, something more safe like R square or low dose benda with rituxi can be a good option, which is a finite treatment because ibrutinib is infinite.
Yes. You have answered the questions. I believe in that. That BR or R square could be useful. But when you look into how much bone marrow clearance does BR or R square does, it is not that much. And these are compartment addressing drugs, ibrutinib and venetoclax. Now, close to 2% of these non-nodal mantle cell lymphoma who require treatment, they could be TP53 mutation positive. So you have to first rule out a TP53 mutation in these cases. If it is TP53 mutation, it should be ibrutinib followed by venetoclax. But if it is TP53 negative, we should use BR first. But I guess even after 4 or 6 cycles, if they are not clearing in the bone marrow, venetoclax rituximab could be an option.
Excellent talk, Dr. Ranjit. I just want to ask the other extreme. So, if a transplant eligible patient but has a localized mantle cell, would you consider transplant for him as a consolidation?
No.
What would be your
mantle cell
choice?
Lymphoma, they are chemoimmunotherapy. I would say it should be bendamustine rituximab for 4 cycles followed by radiation, local radiation.
And maintenance, retux.
Sorry?
And retux maintenance.
Retux maintenance is localized. It is actually not very clear. I would be very skeptical label it as localized mantle cell lymphoma. I would rather do endoscopies and prove it that this is stage 4. Yes. So I would say it should be BR 3 to 4 cycles followed by IFRT.
So Lingraj.
In a nodal mantle cell, do you do TP53 as a routine and do you decide your treatment based on that? I'm not asking about leukemia, nodal.
We actually don't do TP53 mutation very routinely, but it can actually add to your treatment decision. Now, reducing the cost that way, I have actually not discussed in that slide. I was rushing it through. Those who are nodal and they could be TP53, they have a close to 3/4 will be expressing P53 by ISC. So you can get a hint. Or you can get a hint about the Ki67 if it is beyond 30%, 40%. So they are the cases where you should actually look for TP53.
So in a young fit 50 positive, will not recommend auto transplant. Will directly recommend allo transplant.
No. If he is young, I would rather give him some time and then take him from allogenic. Yeah.
So thank you so much.